Good evening, and welcome to tonight's clinical seminar from the Children's Mental Health Resource Center, the DSM, how and why the DSM fails providers and their patients. For those of you who are new to CMHRC, I'd like to introduce myself. My name is Elizabeth Errico, and I am the Executive Director of CMHRC. And our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and bipolar's newly identified phenotype dubbed fear of harm, or FOH. We are a national nonprofit, and in order to fulfill this mission, we have a series of programs and services that we offer to families as well as providers in the mental health care and physical health care fields in education, in order to help support children and families receiving an accurate diagnosis and effective treatment as quickly as possible. The national average, according to the National Institute of Health, from the time symptoms first appear until effective treatment begins, is an average of 10 years. That treatment onset delay is, in our opinion, far, far too long, and everything we do is designed towards shortening that time as well as improving quality of life for children and families in that intervening time as they seek treatment. Our programs are designed around these principles. We have parenting classes. We have a web app for tracking symptoms, medications, and mood. We have a book club where families and providers get together to discuss books relating to children's mental health and mood disorders. We have professional discussion groups where interdisciplinary teams of providers are able to come together and discuss cases confidentially, or learn more about bipolar disorder in children, or to learn more about the diagnosis FOH. We also have custom support services that involve our mental health practitioners meeting with families to help them understand their diagnoses, help them navigate their mental health needs at school, and to help them manage transitions when moving from one provider to another. You can find information about all of these programs and services on our website, which is at cmhrc.org. Now, many of you may be interested in finding out how to receive a certificate of attendance or completion for being at this seminar. I'm going to let you know now and at the end that certificates are only available to those who were here for the live presentation. So tomorrow, after the presentation is completed, you will receive an email from Zoom thanking you for attending. If you attended our live event, that email from Zoom will contain a link where you can request the certificate. It costs $5, and that is just a small fee for us to cover the preparation and distribution of those certificates. So look out for that in an email from Zoom tomorrow. Now, tonight, we are going to be discussing something that is actually somewhat controversial: how and why the DSM fails providers and their patients. I see someone has raised a hand. I'm going to ask that everyone not raise your hands during the presentation. I am on my own tonight. I will not be able to answer questions in the middle of the presentation, but when the presentation is over, there will be time for a Q&A. Please, during the course of the presentation, put those questions that you may have into the Q&A so that when the presentation is over, I can pull that up and we can go through your questions one by one, and I promise that we will get to as many as we possibly can. So please go ahead and use the Q&A box to record your questions. So now, how and why the DSM fails providers and their patients. This is a controversial topic. And it's controversial in part because, for the most part, providers have not ever really been taught anything about the DSM's creation. They've just been taught how to use the DSM in order to find a diagnosis, assign it, use the diagnostic code that the DSM provides to put on insurance forms in order to file for reimbursement, or to give insurance forms to their patients so their patients can file for reimbursement directly from their insurance company. But the DSM has a long history that demonstrates that there are some flaws within this book, and being able to recognize them makes every practitioner stronger in their professional competence and in their area of expertise, because it allows them to navigate the book in a more informed way. So we're going to begin tonight sort of talking about the structure of the DSM, how it was developed, how it's designed to be used, and how those things significantly impact how we view the mental disorders that are contained within it. So we all know, as I mentioned, that we have to use the diagnostic codes that are in the DSM in order to get reimbursement for our services from insurance companies. That makes us as a field very dependent on this book. And it leads us to believe falsely that there is some fundamental objectivity to this book, and that it makes everything that's contained in it correct, unchallengeable, or essentially written in stone. And when we talk to providers about, for example, diagnosing bipolar disorder in children, very often the response that we get is, well, I can't do that because it's not in the DSM. Or when we talk about diagnosing bipolar's newly identified phenotype, FOH, they say the same thing, well, I can't diagnose it because it's not in the DSM, which then leads providers to also think that if something isn't in the DSM, it doesn't exist, or that the only things that exist are the things that are already listed in the DSM. So I think it's really important for us to examine this structure of the DSM so that we can view it and our clients objectively. So the truth is that the DSM had much more humble beginnings than how we use it now. Before insurance companies got involved, the original purpose of the DSM was to classify observable symptoms into diagnoses, and so that providers could have a common language to talk about symptoms and how they cluster. Now, one of the problems with the definition of classifying observable symptoms is that if it's observable, the term for it is actually a sign, not a symptom. A symptom is something that is subjectively experienced by the client. A sign is an observable, objective measure that is seen, noted, and cataloged by someone outside of the patient themselves. So in the case of children, this could be teachers, this could be parents. In the case of people of all ages, it can be their therapist, it can be a case manager, it can be a psychiatrist, it can be a pediatrician or an internist, or somebody else who is observing, documenting, and reporting. And those are signs, not symptoms. So first off, we're dealing with a system that is looking at observable signs rather than the subjective symptomatic experience of the client. Now, when the original copy of DSM-1 was produced, this was this goal. When the DSM was being given its first truly major overhaul from DSM-2 to DSM-3, there were a lot of changes that were made to the book's structure. Until 1980, the DSM was really a short book. It was 134 pages long. For reference, the DSM-3 in 1980 ballooned to be 494 pages. And now the DSM-5 text revised edition, which came out last year, is over 1,000 pages. But the third edition of the overhaul came about as a result, actually, of a series of experiments that took place in the 1970s that essentially assessed the reliability and consistency of psychiatric diagnoses. The most famous of these was conducted by a researcher named David Rosenhan. And as a result, they were called the Rosenhan experiments, which some of you may have heard of. These experiments began with Rosenhan sending to 12 hospitals across 5 states. These were psychiatric hospitals specifically, that he sent to them perfectly normal, in quotes, healthy pseudo patients. These were volunteers who did not have psychiatric diagnoses, did not display psychiatric signs, did not experience psychiatric symptoms, but they were to present themselves to the hospitals and report that they were experiencing auditory hallucinations. These subjects were immediately, upon assessment, admitted to psychiatric wards in the hospitals that they had presented to. And then after admission, these pseudo patients had been instructed by the researchers to behave, again, in quotes, normally after admission. And what this meant was they were to conduct themselves as they normally would, not to pretend to have any psychiatric symptoms, not to demonstrate any false signs. They were not to report any more additional hallucinations, and to basically go about their normal way of being while in the psychiatric hospital. All of these pseudo patients after admission were diagnosed with psychotic disorders, and they were prescribed psychiatric medications. They were diagnosed with things like schizophrenia, and they were given these psychotropic medications. Now, when Rosenhan published his findings, a lot of psychiatric hospitals expressed outrage. They insisted that these were not systemic flaws, that these were problems at those specific institutions, and many suggested that if Rosenhan had sent these pseudo patients to their hospitals, then they would have identified them as pseudo patients. They would not have admitted them and not prescribed these medications, et cetera, et cetera. So ever the researcher, Rosenhan publicly agreed to redo the experiments by sending pseudo patients to additional hospitals. And over the following months, out of 250 new patients, 41 of them were identified by these hospitals as pseudo patients. When they arrived for screening, they were identified as pseudo patients and sort of called out as such. Only it turned out that Rosenhan hadn't sent anyone. His experiment at that point had transitioned, and instead of sending pseudo patients, he just told the hospitals that he would be sending pseudo patients to see what they would do. And so 41 out of 250, that's nearly 25% of patients presenting at psychiatric hospitals at that point were identified as being pseudo patients when they weren't, which led to Rosenhan's publication, in which he said, "It is clear that we cannot distinguish the sane from the insane in psychiatric hospitals." That was in 1973. This, as you can imagine, sparked a tremendous amount of debate within the community, and somewhat chagrined, these studies resulted in a design of the DSM for its 1980 publication as DSM-3. Some of the changes that took place in the structure of the book had to do not only with the diagnoses themselves, but had to also do with the purpose. And so in DSM-3, they decided that they would have explicit diagnostic criteria and a multi-axle diagnostic assessment, which was subsequently actually dropped in DSM-5. The multi-axle assessment is no longer included in DSM-5 or DSM-5-TR. And the authors of DSM-3 established committees to determine what diagnoses were going to be included and what symptoms were going to be used in that classification system for what symptoms would appear as criteria for each of the diagnoses. And I want to stress here that these were committees that were put together by the American Psychiatric Association. So of course, they included experts and professionals in the field. But what we had learned from the Rosenhan experiments was that there was no consistency across setting or across provider for what constituted a diagnosis of or a specific diagnosis, or what the symptoms and criteria associated with it were. And so these committees had to make these determinations by consensus. They had to agree amongst themselves what they would and would not include, which fundamentally makes them subjective. So they identified symptoms that they wanted to include as specific criteria for specific diagnosing in order to create reliability and create consistency in diagnosing. This would mean, in effect, that a doctor in New York could see a patient who presented with a specific set of symptoms, and a doctor in California could see a patient present with the same set of symptoms, and that they would then diagnose the same diagnosis. They would be able to talk to one another about this diagnosis, and everyone would know what it was they were describing. Now, this seems like, and was in many ways, a significant improvement over what had been going on previously. But there's one really important thing that we have to note, and that is that the designers of the DSM made a very specific, intentional choice. And this is a quote directly from the American Psychiatric Association, who publishes the DSM, that the DSM was developed with an approach that attempted to be neutral with respect to causes of mental disorders. So now let's think about this for a minute. It means that everyone agreed ahead of time. The committees that were designing the diagnostic criteria for each diagnosis and which diagnoses would be included and which would not, they decided ahead of time that they would not look for, examine, or consider causes for any of the disorders included in the DSM. That means that as practitioners, we do not have any information that will allow us to look for, examine, or consider causes when we are assigning a diagnosis. It is entirely based on observable signs and patient report of symptoms. So as far as the DSM is concerned, there are just clusters of behaviors to observe, catalog, and apply, which has amounted to a system of checking boxes. That we look at the symptom that is reported, we examine the signs that we have observed, and we check the box, check the box, check the box, and then we're done. The diagnosis has been made. So let's ask ourselves, does this simplify diagnosing? Well, yes, it does simplify diagnosing. With a list of symptoms or diagnostic criteria and boxes to tick, it simplifies the process significantly. Did it help with mental health professionals being able to communicate with one another across time and place, and have a continuity in terms of their understanding of the disorder? Again, yes. Absolutely. The language around diagnosing became clearer. The term schizophrenia means the same thing just to everyone. The next question is, did it increase reliability? And yes, it did that too. So what's the problem, you might be asking? The problem is that when it attempted to address issues of reliability and consistency, while it did address issues of reliability and consistency, it did absolutely nothing and has no criteria for, and has since eliminated from the process of diagnosing, validity, otherwise known as the accuracy of the measurement. So this is the dirty little secret that nags in the back of the mind of most professionals, which is that we all know that there are these blurry edges between diagnoses. Criteria repeats itself. Criteria in the DSM exists in multiple different diagnoses, and we have to figure out which ones they are associated with, because these boundaries between diagnoses are extremely porous, which means differentiating between diagnoses is extremely difficult, and making a population within a single diagnosis consistent is extremely difficult. So we're going to start now by taking a deeper look into the DSM's porous boundaries. This is pretty basic stuff that I'm going to start with here, but we all know that the diagnostic criteria is just clusters of symptoms. And we know that to qualify for a diagnosis, the patient needs to show a majority of those symptoms. And depending upon what diagnosis you're looking at, the percentage is going to be different. Sometimes it's 5 out of 7, sometimes it's 5 out of 10. For conduct disorder, it's 1 out of 20. But when there are diagnostic criteria that repeat across diagnoses, it's difficult for a practitioner to be able to identify which of those diagnoses the criteria relates to. So we're going to look at a specific diagnosis now. We'll look at disruptive mood dysregulation disorder. So disruptive mood dysregulation disorder involves these two criteria, amongst others: severe recurrent temper outbursts manifested verbally and or behaviorally that are grossly out of proportion in intensity or duration to the situation or provocation. And temper outbursts occur on average 3 or more times a week. Intermittent explosive disorder has the criteria of verbal aggression or physical aggression towards property, animals, or other individuals occurring twice weekly on average for a period of 3 months. The physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or other individuals. And the magnitude of aggressiveness expressed during the recurrent outbursts is grossly out of proportion to the provocation or to any psychosocial stressors. Yes, these two sets of criteria have different specific words that are used to explain the symptoms. But when we as mental health providers are sitting with a family, we have to make a determination based on self-reported symptoms from a child to their parent to us. And then we have to make the distinction between verbal rages occurring on average 3 times a week and verbal aggression occurring twice a week on average. The truth is, we really can't make this distinction. And that's a hard thing to say, but if we are truly being honest with ourselves, we will see that we cannot make this differentiation based on the self-report that we get from clients. And unless that child is inpatient for extended periods of time where these things can be measured objectively by trained staff, we are never going to have the data that we need to be able to make this differentiation. So now we're going to look at a second issue related to diagnosing and with the DSM model, and that is the inconsistency within the population diagnosed with a single diagnosis. And to examine this phenomenon more closely, we are going to look at major depressive disorder. It appears in the DSM-5 TR on page 183, and so you will be familiar with this diagnostic criteria associated with major depressive disorder. But we need to note that in order to diagnose major depressive disorder, we have to identify 5 or more of the following symptoms that have been present during the same 2-week period and represent a change from previous functioning. At least one of the symptoms is either depressed mood or loss of interest or pleasure. So imagine for a moment that you have 2 different clients. We'll call one patient Aaliyah and the other one Bree. And Aaliyah comes into your office and reports that she is experiencing depressed mood most of the day, nearly every day. So you already have one of the essential criteria. Now you have to find 4 more, right? So she's also reporting significant weight loss when she hasn't been trying to lose weight. Next, she's experiencing some psychomotor agitation. She's experiencing feelings of worthlessness and recurrent thoughts of death. And criteria B and C are also met. With this information, we can check these boxes off and without any doubt diagnose Aaliyah with major depressive disorder. Okay. Now Bree comes into the office and she's experiencing markedly diminished interest in or pleasure in all or most activities most of the time, nearly every day. Again, we have one of those 2 required criteria, and now we got to find 4 more. So 4 more, she says she's experiencing weight gain and an increased appetite. She's also experiencing hypersomnia. She's experiencing fatigue and loss of energy. She is experiencing a diminished ability to think or concentrate or indecisiveness nearly every day. Now, again, based on the DSM criteria here, we can diagnose Bree with major depressive disorder without any question. But the question is, should we? Because Aaliyah and Bree don't have any overlapping symptoms. Aaliyah and Bree are reporting completely different symptoms from one another, but because we're getting 5 out of 9, we are able to diagnose both of them with the same disorder. Should we? Probably not. The population of people with major depressive disorder is heterogeneous. It's not homogeneous. That means that we are not really dealing with the same disease across subjects, despite the fact that in both cases, 5 out of 9 of the criteria have been met. So if the symptoms are different and we've ignored causes, why is it that we are labeling these clients with the same disorder? And why are we treating them all with the same medications and psychiatric treatment interventions that would likely affect different causes differently? The truth is that it actually doesn't make sense for us to do any of these things, and this doesn't constitute good treatment or effective treatment, yet we do it anyway. We do it anyway because of how the current DSM diagnosis and treatment model is constructed. We are not encouraged to stop and think about how illogical it is. And so what we learn from this is that without the ability to differentiate effectively between diagnoses because of overlapping symptoms, and because there's no actual homogeneity amongst most patient populations, the diagnostic process becomes essentially guesswork. We've all sat in front of an open DSM and tried to figure out how to diagnose somebody who's presented with multiple symptoms or of multiple diagnoses, that they don't match the required criteria for any one possible diagnosis. And in the end, we just have to make our best guess. Now, these are our best guesses. As mental health professionals, we are educated, we are experienced, we are able to make well-considered, educated guesses. And probably more often than not, we're correct in those guesses that we make. But the truth is that within this system, best guesses is the best that we can do. Add to these difficulties the fact that we as clinicians are very often reluctant to diagnose children with what are considered to be severe mental illnesses like bipolar disorder. And we have a system in which children have trouble being diagnosed accurately. When we understand this, we understand why that 10-year treatment onset delay exists. Now, we're reluctant to diagnose children for a lot of different reasons. In some cases, it is because we are reserving judgment. We want to see whether or not these children outgrow some of these symptoms. Maybe they are related to other issues that will resolve themselves. We want to see if growth, maturation, brain development, social development might change some of the behaviors that are being reported. And we want to see if there are environmental causes that could help resolve these symptoms if the environmental issues were resolved. All of this makes sense because the truth is that the DSM doesn't give us a lot of information or choices when it comes to diagnosing children. So the DSM actually has few, if any, diagnoses for children. Those that do exist are primarily neurodevelopmental disorders, and the remaining disorders in the DSM are written for adult patients, not kids and not teens. This is sort of universal within the diagnostic process, that unless a diagnosis is specifically identified as being one that appears in childhood, such as those neurodevelopmental disorders, the symptomology and the diagnostic criteria included in the DSM reflects adult symptomology, which is different. And when we know that adult symptomology is different from child presentation, then when we're looking in the DSM, we can't feel confident that we are matching reported symptoms and observable signs to the right diagnosis. All of this is why kids who have serious mood disorders, like major depression, like bipolar disorder, are often walking out of our offices with diagnoses like oppositional defiant disorder, intermittent explosive disorder, conduct disorder, ADHD, obsessive compulsive disorder, disruptive mood dysregulation disorder, otherwise known as DMDD, post-traumatic stress disorder, and more. We can easily defend these diagnostic guesses because kids and teens with major mood disorders are showing symptoms that appear in the criteria for these other disorders, like arguing with authority figures, having temper tantrums, sometimes initiating physical fights, not following through on instructions, experiencing recurrent, persistent thoughts that are intrusive and unwanted, having recurrent temper outbursts, and recurrent distressing dreams. All of these signs and symptoms appear in each of these different diagnoses, which means that we are stuck with those blurry edges of wondering whether or not what we're seeing is because of this disorder or that disorder or something else, because we're not examining causes. So without further examination of cause and context, we're stuck with what we call the alphabet soup of diagnosing, the overlapping diagnostic categories and symptoms, which leads to different symptoms being attributed to the wrong diagnoses. And that leads to misdiagnosis. We wind up being afraid to diagnose significant mood disorders like major depression, like bipolar, because as I've said, that the symptoms exist in multiple disorders. And also the DSM doesn't list symptoms of bipolar, for example, that are specific to how they present in children. There is no diagnostic criteria for bipolar disorder specific to children at all. This is where a lot of providers will stop me and say, but isn't this why we have DMDD as a diagnosis? Isn't that essentially bipolar for children? And the truth is that it is not. Symptoms of bipolar disorder include mania and hypomania. And so in the DSM, it will tell you that if you are attempting to diagnose disruptive mood dysregulation disorder, DMDD, instead of bipolar, you cannot do it if a manic or hypomanic episode has ever occurred. Once a manic or hypomanic episode occurs, that child must be diagnosed with something in the bipolar spectrum, because a child with DMDD does not have manic or hypomanic episodes. So again, you might think, well, that's super clear. Now I know. But the problem comes in if we as providers don't know how to recognize what the symptoms of a manic or hypomanic episode are in children in the first place, because they present differently from adults, and there is not a specific criteria list for that unique childhood presentation. And so what we hear from providers over and over again is, this patient is extremely complex and therefore difficult to diagnose. The patient has many symptoms of bipolar. However, these same symptoms are more easily explained by more common disorders such as ADHD. I cannot tell you how many times we have heard that from providers who are well-meaning, who are well-educated, who are trying their darndest to find the right diagnosis. But because the DSM doesn't have the criteria listed that you need, the interpretation is the patient is extremely complex, not that the DSM is failing us by not providing us the criteria we need to diagnose what is coming through our office door. So in this DSM model, what winds up happening is we wind up essentially misdiagnosing children with other disorders, and that is fundamentally unacceptable. It is unacceptable to our patients, and it should be unacceptable to us as professional diagnosticians. We deserve better, and so do our clients. So what do we do about it? Well, first and foremost, we need to recognize that the DSM is not a holy text that can't be questioned. We become better clinicians when we understand what the DSM does well, which it does do some things very well. It is able to provide common vocabulary for diagnostic criteria and diagnoses. But we also have to recognize what it doesn't do well, or what it doesn't do at all, which is A, examine causes, and in many cases, give us unique symptom presentation for children and adolescents. So how do we overcome this? We accept that there's information we weren't taught in school. This is why we have to do continuing education hours in the first place, because our field is a dynamic one. It is continually changing. Research is ongoing. There is new information all of the time that we can be integrating into our practice, our understanding of the field, and our conceptualization of our patients. But too often, I speak to providers who will literally say, I didn't learn about this in school. I don't have time to learn anything new now, so I'm not going to consider it. Needless to say, this is not the best way to serve our clients. We need to open ourselves up to the newly discovered, even if it hasn't made its way into the DSM yet. Now, this is an area where we at the Children's Mental Health Resource Center can help our fellow clinicians. Our diagnostic consultation program works with providers in order to help them do a complete and thorough differential diagnosis, which starts with taking a history of our clients that is much more detailed than we are usually taught to do. Many of us have been taught that we need to be looking at anywhere from the previous 12 weeks to 12 months. But with what we call complex kiddos, what we need to do is we need to look back as far as infancy. And when we do our diagnostic consultations, this is what we do. We collect pediatric records that go back to that first appointment with the pediatrician after birth. And we are looking at biological factors, we are looking at psychological factors, we look at educational records. Literally, sometimes every email that was sent home by the school about a child, records on IEP meetings, 504 plan meetings, interventions. We look holistically by working with occupational therapists, physical therapists, speech therapists, in order to get a total picture of who this child is and the environment in which they function and the family history that goes along with this child in terms of not only their biological family, but other family members who may be adopted, maybe they are adopted, their new family members, and we are looking at school, daycare, everything in order to put together a fully holistic picture of the biological and sociological impacts that this child has experienced and the context in which their symptoms develop. This is an enormous task, and we recognize that most providers are overwhelmed. They have long wait lists, they have paperwork demands, they have other requirements based on the agencies or systems in which they work. And this is part of our service to providers, is that we will partner with you. We will do the digging. We will go through those records in order to provide you with context necessary to feel more confident that you have the full picture before making a diagnosis. Another thing that we need to do as clinicians is we need to trust parents and their reports. Parents are the experts in their children. Most of them have other children as well. They have points of comparison. They have observed their children since birth. They know what their child's triggers are, what suits them, what times of day are more volatile for them than others. We call this a parent professional, that parents are professionals in their children. Parents hold the history of their children, and parents should be trusted partners in the diagnostic process, being detectives together. Too often, what we hear from parents and from providers is that the problems the children are experiencing are because of the parents, that it is a fault of parenting. And while we cannot make a universally blanket statement, because of course there are parents who contribute in some ways to their children's distress. However, parents are not to be blamed by default for the mental illnesses that their child experiences. Nearly all parents of kids with serious psychiatric disorders have heard from someone who was a professional that their parenting was the problem and that they were the biggest contributor to the problems that their children were experiencing. Don't be that professional. Don't jump on the bad parenting bandwagon. Listen to parents. They are with their children 24 hours a day, 7 days a week. They know that child better than anyone else knows that child. Next, we need to embrace and not be intimidated by the time and energy and expertise it takes to do that differential diagnosis. And again, this is a way in which we support clinicians. It is also a way for you as a clinician to expand your professional competence into diagnoses that you don't see as frequently by getting this in-depth approach and partnership from us. We really comb through everything, all the information that parents provide to get a clear picture of context, of causes, and therefore of the most effective treatment interventions that you are going to be able to apply. Next, we need to get together with like-minded providers to discuss cases. Very often as clinicians, we are siloed. Oftentimes we sacrifice supervision time in order to see clients or get paperwork done. And even when we have supervision time, we are most often interacting with someone who has the same professional credentialing and criteria that we do. It is simply more advanced. The best way to be able to fully understand context and causes associated with childhood onset of mental illnesses is to work with an interdisciplinary team of providers who can bring different perspectives, different backgrounds, different knowledge and experience to the table in order to help us understand what we are facing. This can mean that you participate in a team meeting with your clients' other providers. That could be asking the parents to facilitate a conversation amongst occupational therapists, speech therapists, school counselor, and psychiatrist. It could be that you participate in our regular professional discussion groups where we bring together nurses and CNPs and occupational therapists, teachers, social workers, LMFTs, you name it. If they're professionals who work with kids, they participate in our professional discussion groups, which gives that kind of context and information necessary in order to be able to have a truly holistic picture of what's going on with your patients. Additionally, we need to really drill down on what symptoms are most prevalent, most problematic for our patients before we jump to a diagnosis. Giving our clients the tool in order to track their own symptoms and share their data with us gives us a much clearer picture of what is happening with them when they are outside of our office and not able to report to us. Having a simple tool that can track medication impacts, symptoms, overall narrative summaries of how their day is going and how they're interacting with their peers, with their family, with their teachers. It can be incredibly important in the process of identifying what interventions and accommodations are actually benefiting this child. We all know that the old maxim that usually what we hear about in session is whatever happened on the way to the session in the car. And what that really means is that our clients are biased towards telling us whatever happened most recently, that does not give us a clearer picture of what is going on. And so the way to do that is to have some sort of tool for tracking. Now, there are a lot of them out there on the market. We have one that we designed specifically for parents to track the symptoms of their children. This does not require the subjective input of the child, but really looks at signs that parents can observe. It documents medication history, doses, medication compliance. It gives you daily summaries on specific symptoms that are being tracked. It looks at the local weather, and it gives you the ability to graph all of these data points so that you can pinpoint when this medication change happened, this happened to the presentation, prevalence, and intensity of symptoms for the child. Now, if you as a provider want to use this, you can set up an account. The best thing about it is we don't do any upcharging for the number of clients that you want to have using it. It's one account, small subscription fee on a monthly basis, and you can use it with as many clients as you want, which means that you can look at any point and see what is going on with them right now, rather than waiting until they come in to see you or call for an emergency session. Now, there are cultural issues to be considered here. We've talked about the fact that the DSM is written without specific criteria for children for most of the diagnoses that are not considered to be neurodevelopmental or onsetting in childhood typically. And so that is a first issue when we recognize that children are their own demographic, that adolescents are their own demographic. We're able to recognize that that whole group of people, that whole population is being marginalized by the DSM. The DSM has also been criticized for the degree to which it pathologizes behaviors and practices that are deemed to be abnormal by Western cultures. In 2016, an article in Canadian Medical Association Journal pointed out that the culture sections provide a kind of apology for the DSM, but it seems like a shallow apology. Why is it shallow? It is shallow because what is presented as culture in the DSM-5 is too focused on meaning and not enough on practice. Nowhere in the DSM's lack of cultural sensitivity is it more on display than its approach to gender and sexuality. It was not until the release of the DSM-5 in 2014 that distress over one's sexual orientation was removed from the DSM as a diagnosable disorder. For context, the state of Massachusetts legally recognized same-sex marriage in 2014, a full decade before the publication of the DSM-5, and the Netherlands was the first country to legalize same-sex marriage in the year 2000. The American Psychiatric Association, which publishes the DSM, began its reassessment of homosexuality, in quotes, back in 1973, when they replaced the diagnosis with the category of sexual orientation disturbance, in which sexual orientation disturbance was defined not just as same-sex attraction, but as a conflict caused by this attraction or a desire to change it. In 1980's DSM-3, it was renamed ego dystonic homosexuality, and in 1987's DSM-3 text revised edition, it was amended again to be sexual disorder not otherwise specified. And it was finally removed from the DSM in 2014. Again, a decade after same-sex marriages had been legalized in the state of Massachusetts. Some could argue that this systemic de-emphasizing of this disorder can be seen as a long-term laying of the groundwork for its removal from the DSM entirely. But it still perpetuated 40 years of marginalization of an entire group of people who were pathologized for something that is not truly a psychiatric condition at all. The DSM is going through these same processes now with regards to gender identity, which remains in the DSM as a diagnosable disorder called gender dysphoria. And the introduction to that section states that gender dysphoria refers to the distress that may accompany the incongruence between one's experience of depressed gender and expressed gender and one's assigned gender. Apologies for the typo on that slide. One could be forgiven for hearing this and thinking that the APA was moving away from pathologizing and medicalizing transgender identities. But one look at the diagnostic criteria for the disorder makes it clear that it is not the case. None of the diagnostic criteria, 8 in children and 6 in teens and adults, addresses the distress that may accompany the incongruence. In fact, each begins with the phrase, or a phrase like, a strong desire to, or a strong preference for. And none of even the secondary criteria addresses that the condition is associated with clinically significant distress or impairment in social, school, occupational, or other important areas of functioning. It approaches all of this from the perspective that the distress is because of the gender dysphoria. Each of these things addresses the fact of that potential experience, and that it is caused by a marked incongruence between a person's expressed gender and assigned identity, or excuse me, assigned gender. This does not take into consideration that that distress could be caused by the social and emotional responses to them by others. That perhaps the distress that goes along with it is not because the individual recognizes that they are transgender, but instead that it could be caused by the fact that they're experiencing discrimination and marginalization. This framing continues to pathologize and stigmatize transgender individuals, as well as the entire transgender community. And whether intentional or not on the part of the APA, it contributes to the violence that is perpetrated against transgender individuals and serves as a justification for discriminatory practices and policies, including a rash of anti-transgender laws and legislation that is being proposed across the country in state legislatures almost everywhere. While some may argue that the DSMs, again, shift from focusing on homosexuality and gender as pathologies to internal conflicts, is somehow moving the needle, that it is reflecting the changing cultural norms of the nation, and that it is a trailing indicator of those shifting cultural norms. But we would argue that the DSM must lead, not just reflect. It is in a position to be leading indicator of that cultural evolution, not simply to reflect it, and that removing gender dysphoria from the DSM would not only depathologize, but also impact the foundation of what is considered to be pathological in the first place. Second, this shift in diagnostic categorization based on changing cultural norms simply highlights and underscores the fundamental lack of validity in the DSM's diagnostic system. If the diagnosis can change based on cultural norms, then its causes don't lie within the individual patient, but in society at large, which it isn't and can never be the patient that is sitting in the office with you seeking treatment. We as providers are not treating the entire society. We are treating a person, and that person, regardless of cultural factors, regardless of age, regardless of diagnostic criteria, must be our primary concern first and foremost. So I want to thank you all for being here with us tonight. This is a slide that has the references that were used in the construction of tonight's presentation. And I would like to remind you that we provide opportunities to talk about these clinical seminar topics in more detail with more dialogue and exchange of information in our professional discussion groups, which start up regularly. If you are interested in taking part, please email learning, LEARNING, at cmhrc.org. And we will get you set up to participate in one of those discussion groups. Again, certificates of completion are available for those who attended our live event, so check your Zoom email tomorrow with a link to request a certificate.